Well, good evening. My name is Mahmoud Aljurf from King Faisal Hospital in Riyadh, Saudi Arabia. What I'll be talking about in the next 20 minutes is to give sort of update about diagnosis and management of acquired bone marrow failure. I will be talking about pathology diagnosis, supportive care, immunosuppressive therapies, and new therapies and ongoing trials. Would not be talking about transplantation, as that by itself is a different topic and needs a separate lecture. Uh, Starting by talking about pathology and underlying pathology of acquired bone marrow failure, most of the work in the last 10 decades had focused on three fronts in research of pathology of aplastic anemia. The first of which is the role of cytotoxic T cells as being the main immune effector cell involved in acquired bone marrow failure syndrome. And if the cytotoxic T cell targets early stem cells, this will lead to aplastic anemia, and if it or myelodysplastic syndrome. But if it involves a more mature stage of hematopoiesis, then you may end by having autoimmune neutropenia or autoimmune pure red cell aplasia or other autoimmune disorders. Now, the other research front that is going on in relation to pathology of aplastic anemia is the defective regulatory T cells, or what's called Treg. Uh, Regulatory T cells are implicated in the suppression of immune responses and maintenance of tolerance. It's well known that and most of the studies had indicated that the number of Tregs are decreased in most of cases of aplastic anemia and autoimmune disorders. The third research front that is being uh, researched in relation to bone marrow failure is the telomere shortening and tissue repair and regeneration defect in bone marrow failure. And it's well known that this is an important mechanism. There is this important mechanism for tissue maintenance, and if there is a telomere erosion affects the stem cell, this will lead to bone marrow failure. And if it affects organs like lung or liver, you may have things like pulmonary fibrosis or liver cirrhosis. Typical example of telomere problem is dyskeratosis congenita. Uh, Obviously, telomere disease, failure, and malignancy is an active research area, and this is a new class of molecular disease. Telomerase machinery mutation may manifest only in increased demand or hematopoietic stress or later in life. Uh, and it's implicated in the pathophysiology in some cancers, and it's being used also as a prognostic factors and targets for therapy. Now, moving and talking about the differential diagnosis of aplastic anemia, the most important is to differentiate aplastic anemia from hypoplastic myelodysplastic syndrome and PNH, and to be kept in mind that there are overlap syndromes where you may have aplastic anemia PNH syndrome, sorry, or you may have an overlap between MDS and aplastic anemia, typically hypoplastic MDS with limited dysplasia. And some of the patients may have also MDS with like PNH markers. So this is always to be kept in mind and the most important and relevant differential diagnosis. Now, uh, distinction between aplastic anemia and hypoplastic MDS given in this table and shown here. This erythropoiesis frequently present in MDS, sometimes in aplastic anemia. Anytime you have a stressed marrow or stressed erythroid, you may have that touch of dysplasia, but typically more advanced in myelodysplastic syndrome. Abnormal neutrophils is seen in MDS, dysplastic megakaryocytes more in MDS. fibrosis occasionally observed in MDS, abnormal localization of immature precursors is seen in MDS, increase in CD34, which is like blast or stem cells, sometimes seen in MDS, but typically not in aplastic anemia. Clonality, more typical again of MDS, possibly seen in some cases of aplastic anemia. And one important thing to keep in mind that aplastic anemia never have enlarged spleen or splenomegaly. The other important differential to keep in mind always is hairy cell leukemia. Traditionally, these patients will have dry aspirate and hypoplastic bone marrow. But what it is like very important and serious mistake to mix hairy cell leukemia with aplastic anemia. So careful look at bone marrow for this particular other differential possibility should be kept in mind. Now, as it comes to cytogenetic investigation, due to hypocellular bone marrow, frequently you have insufficient metaphases. And what always needs to be done is to do FISH for panel for chromosomes 5 and 7 to exclude MDS, MDS panel basically. Abnormal cytogenetic clones does not imply that the diagnosis is MDS or AML as we come in the next few slides. And as I have mentioned, so karyotypic abnormalities have been observed in up to different studies, 10 to 15% of typical cases that appears as hypoplastic bone marrow or aplastic bone marrow, no dysplasia. Careful evaluation may reveal abnormal karyotype in about 10 to 15% of the patients. Trisomy 8 is like one finding that sometimes can be discovered and what found in some of the aplastic anemia cytogenetics, and it is interesting that it is a surrogate marker of responsiveness to immunosuppressive therapy. Additionally, one has to screen for inherited bone marrow failure disorders. Most notable or most frequent or common is Fanconi anemia, where you will have a positive chromosomal break test, mitomycin C or diboxybutane, um, and these two still represent the diagnostic gold standards. Of course, now we have next generation sequencing and other more refined molecular techniques. The other differential to be kept inherited disorders, dyskeratosis congenita, and the typical screening is the telomere length, and this is frequently associated with TERC or 30 mutations. And in Saudi Arabia, in our region, most notable other, less common phenotype is NOP10 mutation. Now, moving and talking about supportive care for aplastic anemia, three things to keep in mind: the transfusions, iron chelation, and in relevance to this, to be kept in mind that electrombobag is a very, very effective iron chelator, very effective in iron chelation, and also prophylactic treatment of potential infections in patients with extended neutropenia. Now, going back to transfusion policies in aplastic anemia has to be a restrictive transfusion policy and use platelet transfusions in case of bleeding only, and the prophylactic transfusion when platelet count is less than 10 only. Some centers, they use even lower cutoff, something like 5, and less than 20 in case in the presence of fever or infection or during ATG administration. As it comes to red blood cell transfusions, is to be used in case of hypoxic anemia and based on symptoms and comorbidities, but traditionally should not transfuse a steady state patient with a hemoglobin of greater than 8 or 80. Now, this is an interesting study done by Dr. Richard Champlin from MD Anderson Cancer Center showing the risk of graft failure in relation to the number of transfusions. Patients who had received more than 60 units of transfusions, the risk of graft failure is about 35%. Obviously, a patient who is a potential candidate for stem cell transplantation should always avoid transfusions from family relatives. Now, how about growth factor as a supportive care measures? Frequently used, but in reality, this is a meta-analysis that was published in Hematologica in about 13, 14 years ago, and showed that the overall outcome was not affected by the GCSF administration, and including documented infections or severe infections. Now, moving and talking about therapy of acquired aplastic anemia, and first thing, traditionally immunosuppressive therapy has excellent response in aplastic anemia, particularly in pediatric patients. And it's also well known that higher ANC is associated with favorable response. And keep in mind also that responding patients are less likely to progress to clonal disorder. Um, Clonal abnormality frequently disappears with response to therapy, and short telomere in peripheral blood white blood cells is associated with higher risk of relapse after treatment with immunosuppressive therapy. Now, listed here are the recent and ongoing trials. Several trials looked at horse versus rabbit ATG, obviously in combination with cyclosporin, showed that has greater advantage over rabbit ATG. Rabbit ATG is a more potent immunosuppressive therapy, high risk of infection, and in the EBMT study also more renal impairment was observed with the rabbit ATG. So the standard for immunosuppressive therapy, first round, is the horse ATG. Now, subsequent trials looked at use of electrombobag in aplastic anemia, and this is the famous trial that was done by the National Institute of Health in patients who were refractory to first-line therapy, immunosuppressive therapy. A substantial percentage responded to electrombobag. The next generation trial was the combination of cyclosporin, ATG, and electrombobag, and this is the famous paper by Dr. Phil Schamberg and Neil Young from the National Institute of Health that showed impressive response, total response close to 80-90%, with significant proportion having complete response. So this is becoming more or less the standard use of ATG, cyclosporin, and electrombobag. A trial that have tested cyclophosphamide moderate dose earlier trial showed some favorable responses, but subsequent trial showed significant toxicity, and this did not pan out as a potential treatment for aplastic anemia. Being an autoimmune illness, people have tried longer and long-term cyclosporin administration to prevent relapse, even beyond complete response, to keep it and the slower tailing off of the cyclosporin to prevent relapse. As mentioned early, androgens being used to treat aplastic and bone marrow failure, and this kind of therapy is more widely used in Europe in patients who had failed the previous immunosuppressive therapy or elderly patients. And data, as I've mentioned, are emerging that it can help patients with telomere disease. Uh, and the last is the addition of mycophenolic acid to standard ATG and cyclosporin. They did not end by bringing more responses, and not, studies were not in favor of adding this as additional immunosuppressive therapy study by the NIH. Now, one thing to keep in mind, patients who cannot tolerate ATG, Campath, ilimtuzumab can be considered obviously as a second line, more relevant, and this is few trials done mostly in the National Institute of Health showed that Ilimtuzumab Kempath can be used as a second line therapy with good responses. Now, listed here are the available anti-lymphocytes preparations. Uh, the original product that was available, lymphoglobulin horse, have been discontinued and not available, no longer available anywhere in the world. The only, practically speaking, the only horse preparation that is available in the market is Atgam Pharmacia Upjohn product now being marketed by Pfizer. And this is commercially available, obviously being widely used in organ transplant, was not available in Europe or not like approved by Europe by the EMA for this indication. Maybe this is probably all the slide, don't know, maybe subsequently have been approved. And obviously there is the rabbit preparation, which is thymoglobulin of Sanofi, and this can be considered as a second line agent. And there is the Fresenius, which is now Nuvi company, which is a product against T-cell lymphoblastic cell lines, is available in the market as a rapid preparation. Now, surrogate markers for responsiveness to immunosuppressive therapy includes the presence of PNH markers and HLDR2, particularly HLA-DR B115, 1501 and 1502, the presence of trisomy 8 and deletion 13q of interest, as mentioned in the earlier slide. Both of these abnormalities disappear with response to immunosuppressive therapy. Now, the relevance of molecular markers in treatment and prognosis of acquired aplastic anemia is being recognized more and more, particularly in the last 5 years, where molecular markers like B-core and obviously PIG-A mutation, which is a PNH marker, carries a favorable prognosis, while myeloid mutations like A6L1, DNMT3 has um, uh, uh, poor risk molecular markers in aplastic anemia and higher risk of progression to myeloid disorder or myelodysplastic syndrome. Now, as I've mentioned, immunosuppressive therapy, excellent outcome in pediatric patients, can be up to 80 or 90%. Higher ANC is associated with higher response. Responding patients are less likely to progress to clonal disorder. This is to be kept in mind. Okay. Clonal abnormality frequently disappears with the response to therapy. Still, there is a risk of progression to clonal disorders. That's why you would, in a young patient, you still would favor transplantation over immunosuppressive therapy. And as I've mentioned, shorter telomere in peripheral blood white blood cell is associated with high risk of relapse and clonal evolution. Now, if you need to retreat for patients who had failed immunosuppressive therapy, always repeat bone marrow biopsy to rule out MDS and do next generation sequencing to exclude constitutional syndromes. Repeat course ATG, use horse also, responding good in relapse patients who had a period of remission. But if the patient is refractory to the first round, there is no point of to use horse ATG. Keep in mind that about 7 to 40% of aplastic anemia patients are found to have mutations of big A mutation, not necessarily the clinical syndrome. Uh, the clones, though typically small and are found in substantial percentage of the patients at the time of diagnosis as laboratory markers, but about roughly 20% will eventually develop overt PNH clinical syndrome and other clonal bone marrow failure disorders. As I've mentioned, Aplastic anemia with mutations of DNMT3A or A6L1 are shown to exhibit 40% chance of EVA developing MDS, which is far more significant than observed 10% incidence of such uh, problem in aplastic anemia in general. Always to keep in mind, always avoid using oral contraceptives in severe aplastic anemia patients at risk of thrombosis, particularly PNH positive patients. Now, what's the role of transplantation? Patients, this is a relatively maybe updated now a slide from guidelines, British Society, uh, Hematology, uh, uh, and this is younger patients if they fail immunosuppressive. I mean, if they have a full match donor, that's the preferred modality of treatment. But nowadays, with the availability in younger patients, data on haplo and mud donor are numbers are very favorable, and it's a choice also to give to do haplo, obviously, definitely full match mud or haplo transplantation. In older patients, always preferable to older than 50 to start with immunosuppressive therapy. Obviously, this means ATG, cyclosporin, and erythrombobag. If there is no response or refractory, then consider unrelated donor. Of course, if there is a matched donor, then you do matched donor. If there is no matched donor, then you do unrelated or haplo. And those who doesn't have haplo or unrelated, they are the candidate for alternative like cords or alternative protocols. Now, the debate is for patients between age 40 to 50, and this has to be judgment to be used if the patient has signs or findings of low responsiveness to immunosuppressive therapy, then a transplant option will be favored. And with that, I will conclude and thank you for your attention.